Shifts gears a little bit. Again, a lot of what has come before has been examining, to oversimplify a bit, the impact that psilocybin and metabolites have on the body and the brain and the value that that may have, where this talk is going to be focusing on how the body handles psilocybin. And it takes a village to do research such as this, and this is our small village here. Our principal investigator and pharmacologist, Paul Hudson, sends his apologies for not attending. He understandably felt like he was not able to miss his son's graduation this weekend, so I had the good fortune of coming in his stead. Our research coordinators, Michelle Gassman, Kelsey Enriquez, and Nancy Arnold, kept the machine running smoothly, and then you see our names, Chantel and Christopher, Karen and Dan, who were our guide dyads for the psilocybin session, and Nick Cozy, the pharmacologist who synthesized the psilocybin preparation that we used in this study. And then we also should certainly send out heartfelt thanks to the psilocybin research group at Johns Hopkins, who were very generous with their time and expertise coming out to get our group trained up so that we could run a safe and comforting experience for our subjects. So while this, again, is getting at perhaps the less sexy topic of pharmacokinetics and not engaging in exploration of mystical experience and its value, it's still timely and important work, because one of the goals of a lot of the things that we are doing in psychedelic research is to disseminate its therapeutic potential and to get these therapeutic platforms approved so that they can be of assistance to individuals struggling with often refractory conditions. And so this study in part serves some of that purpose by exploring some of these issues around how the body handles psilocybin, how it's metabolized and cleared. Do we need to engage in individualized weight-based dosing, or might flat dosing for adults be a reasonable thing to do? And while hundreds of subjects have gone through a number of protocols with varying indications for its use, there was also some requirement in this study to be doing some monitoring around safety as well. And so those are the results that I'll be discussing. So as such, the goals for this work were to determine the pharmacokinetics of psilocybin and its main metabolite, psilocin. I won't be presenting these results today, but we also were looking for changes on the electrocardiogram, some concern with substances around prolongation of what's called the QT interval that can lead to problematic cardiac rhythm abnormalities, something to be explored. We're still evaluating those data. We did not have any such events, but we're still looking at sort of our data around the QT interval prolongation. I'll be describing our protocol for increasing doses. And again, ultimately, the goal is to be moving toward FDA and EMA approval of therapeutic regimens for these substances, with likely the first and primary indication being cancer-related anxiety or existential distress. So how did we go about this work? We were able to recruit 12 healthy adult volunteers. 30 were screened. This took place through word of mouth and what are called chain referrals. It's sometimes called snowball referrals. There were kind of a network of psychedelic therapists in the area, and they were asked to refer subjects our way. And they could also refer individuals who they knew had positive experiences with psychedelics in the past as well. Through the course of our screening process, let's see, is this pointer? No. Is the pointer still up here? Maybe, maybe not. We can do without, I suppose. You can see the numbers in parentheses indicating, great, thank you. The reasons for which subjects were excluded, with the most common being a personal or family history of psychotic disorder such as schizophrenia. We also include their bipolar spectrum disorder, Those were by far the most common issues. There were a couple subjects lumped in here, one of whom was on stimulants for an attention deficit disorder, the other of whom had had severe depression with suicide attempt within the last couple of years. A few, though on initial screen, had endorsed some prior mystical experience. It was found a more detailed interview that was in fact not the case. Uncontrolled hypertension, one. As a part of this study, we needed to maintain intravenous access throughout the day for purposes of blood sampling. So if we weren't able to do that, that was a reason we had to exclude some volunteers. And one subject was excluded for electrocardiographic or cardiac conduction abnormality. And these don't quite add up to the total number excluded. The other, I believe it's 2 that are not included there, were excluded simply because they didn't feel comfortable with having to be present in the setting for an overnight stay, which was a requirement of the study. So we've heard quite a bit about the importance of set and setting, so I won't belabor these points, but we got a lot of guidance from others involved in the field. And if we're simply doing pharmacokinetic studies, why engage in this process? Well, again, as others have explained, this, we think, leads to a lower likelihood of an individual having an unpleasant experience, or if they do start having that, that we are better able to support them through it. So we also engaged in a process of 6 to 8 hours of orientation and rapport building with the guide dyad, where they went through their life story, learned some meditation techniques that might have been helpful to them if they did encounter unpleasant experience during the psilocybin session. There was also clear communication around how the subject wanted to be communicated with, including how should the guide dyad use touch to provide comfort and issues like that. There was also instruction and kind of dry runs on some of the procedures, like having an intravenous line placed, experiencing what a blood pressure cuff feels like, and the like, which surprisingly was nothing that subjects complained about during the psilocybin session itself. One might think that having to have those things in place during a 6-hour psilocybin session would cause some unpleasant sensations, but actually a couple of subjects described the blood pressure cup as like receiving a hug. So we also engaged in a debriefing or an integration session after their overnight stay, the morning before they were discharged. Others have also shown the setting. This is what our setting appears in Wisconsin. Again, homey appearing living room environment with a bathroom immediately adjacent, refreshments immediately available. And after they'd had their IV placed, had some orientation, day of dosing, were led to this room on 3 different sessions and escalated doses given. And you may notice that we really pushed the envelope up here. In fact, when we mentioned to a number of experts in the field that we were doing this, they said something akin to, "You're doing what?" And so why would we go there? Well, in part, understanding the pharmacokinetics of these higher doses may be important, but this decision was also based on personal communication with investigators like Michael Bogenschutz, who's doing work with alcohol-dependent individuals, who gave some indication that actually individuals suffering from more severe addictions tend to have a higher threshold in terms of dose so far as getting to a potentially therapeutic mystical experience, and so some investigation of higher doses is probably warranted. And as you can see throughout their day, extensive sampling was done at a quarter hour, 15 minutes, half hour, 45 minutes, and so on throughout a 24-hour time span. Their urine was collected throughout the 24 hours, and electrocardiograms were repeated at these time intervals to assess for any cardiac conduction effects. This is generally what our sample looked like. As you can see, we had a predominantly male sample, fair range so far as age goes. quite a range so far as weight goes, with one individual exceeding or getting to 120 kilograms. Down below, you can see the dose ranges that we landed on for each session, which again, in this case, for the purposes of the pharmacokinetics study, were weight-based. So the plasma and urine samples were collected on site, analyzed according to good laboratory procedures at a local laboratory. And you see the threshold for detection here of psilocybin and psilocin in plasma and in urine. And in fact, we detected no psilocybin in any of these plasma or urine samples. Right now, I suppose some of you may be turning to your neighbors and saying, hold the phone, these people gave people psilocybin, couldn't detect it in plasma or urine. These people clearly have no idea what they're doing. But as many of you may know, the reason for that is as follows. Psilocybin, upon ingestion, is lightning quick metabolized to psilocin, the primary active substance. And the majority of my remaining slides are going to be discussing how the pharmacokinetics look relative to psilocin, again, the primary active metabolite that we're finding in urine as well as in plasma. So far as the adverse effects monitoring, again, hundreds of subjects have gone through other studies, and this is a sample of 12, so I won't belabor this point either, but we confirmed what others had found as well, that common things were common. We saw a headache in the majority of subjects that was mild and responsive to acetaminophen on the night of their overnight stay. Low-grade mild tachycardia and hypertension or fast heart rate, elevated blood pressure that almost universally were as expected at about the 2-hour time point or when psilocybin was reaching peak effect. Whether that's a medication effect itself or an effect of the intensity of the experience at the time is a bit difficult to tease apart. But we did not have any serious adverse events during the course of this study. So then to get to the real meat of what we were looking to demonstrate with pharmacokinetics and how the body handles psilocybin, this was kind of the idea, was what we were hoping for was that psilocin would demonstrate desirable pharmacokinetics, that elimination would be linear, not dose-dependent, and the area under the curve, and I'll explain that in just a second, just in case there are those not familiar with that, and that the maximum serum concentration, or Cmax, would increase linearly with dose or wouldn't behave in some other more difficult to predict manner. And so when we're talking about area under the curve, this is what we're talking about, where this is serum concentration. The x-axis here is time, and you're seeing this concentration, of course, decrease over time. And area under the curve, of course, describes this entire area that is an indication of how psilocin is eliminated. So that's one very traditional measure, as is the maximal concentration, which is essentially determined by an inspection of these data points over time. And on this next slide, this is one aspect of pharmacokinetics where we did demonstrate that desirable set of linear pharmacokinetics. What you're seeing here are the plots over dose, with each line representing a different subject. Here for psilocin versus dose in milligrams. Here for psilocin serum concentration versus weight-based dosing. And in each of those cases, this dotted line describing that overall data is a straight line with a non-zero slope demonstrating those desirable pharmacokinetics. So similarly with maximal serum concentration, we're seeing that linear relationship between dose and maximal serum concentration between subjects when we look at absolute milligrams and when we look at weight-based dosing, or milligrams per kilogram. So to summarize that piece of things, psilocin does appear to demonstrate desirable linear pharmacokinetics. So that was good news, but there were still a couple more steps to take here, one being renal clearance, with a potential concern there being, might the dose of psilocybin need to be adjusted for individual renal function? And this slide and the next are essentially indicating that it looks like no, we don't have to. And why do I say that? Well, one, psilocin, the vast majority of it was not excreted in urine, less than 4% of what we expect. So where is the rest going? Okay. Likely other metabolites are inactive or fecal excretion. And so if psilocin is the major active metabolite, then dose adjustment for those with renal impairment is likely not needed. And this slide simply demonstrates that as well, where you see the relationship of psilocin clearance to creatinine clearance, and these dots are just kind of scattered all over. There wouldn't be a line that would systematically summarize those data. So as I'm running a little low on time, I'm afraid I'll go a little quickly through this next piece of modeling, where the idea was to try to model whether psilocin is distributed into 1, 3, 2, or 3 anatomic compartments, with 2 being one of the simpler, being serum, and 1 tissue compartment. Sort of a classic example of something more complex would be cannabis, where THC is quite widely distributed in a 3rd or fatty tissue compartment that complicates pharmacokinetics and elimination quite a bit. So we entered some of the dosing data and underwent statistical modeling. And a 2-compartment model did prove to be the best fit, and adjustment for clearance and volume by weight did not add anything, and neither did renal function. And this next slide sort of gives a picture of that may make that a bit more understandable. What this is demonstrating in these panels is the statistical model for elimination, the actual measured data points around it, adhering fairly closely to that line in the overall study sample, and then here where individuals were treated as a random effect or allowed to vary. And these last 2 panels simply demonstrating that there didn't appear to be systematic bias so far as difference between predicted and measured values based on dose. So that demonstrates something similar. So far a lot of studies have done weight-based dosing, but the importance of this work in figuring out the pharmacokinetics really is here for these larger phase 3 studies, where we hope to seek FDA, EMA approval for a psilocybin-based therapeutic regimen to alleviate cancer-related anxiety. Those studies are going to be much facilitated greatly if we can be using a flat dose of psilocybin rather than needing to measure out individual doses and ship out individual capsules for individual participants. So in order to demonstrate that, we took these pharmacokinetic models and sort of laid them over flat doses of 20 and 25 milligrams for the 0.3 milligram per kilogram dose. And what we can see here is these slides here demonstrating, so there's concentration of psilocin, time after dose, psilocin concentration, time after dose for the 20 milligram dose on the left, and for a 25 milligram dose on the right. And it's looking like this 25 milligram dosing model pretty closely, adheres pretty closely to this 0.3 milligram per kilogram weight-based dose. So the 25 milligram dose is probably going to work out pretty well there for future study, as opposed to here, where if you're comparing this dashed blue line to the measured observations, there's quite a difference there so far as the peak, which wouldn't be desirable. So to summarize there, we think that a flat dose of 25 milligrams will match pretty well to the weight-based dosing done in several studies of 0.3 milligrams per kilogram. there was a bit of skew due to the larger subject, the 120 milligram subject, so we may need to allow for some dose titration. So we still need to answer some questions about the packaging. You know, we may not just want to have 25 milligram formulations available as we're going to good manufacturing procedures for phase 3 trials. We may need kind of some additional smaller dose capsules so that we can get participating subjects appropriately dosed to the point where they get that therapeutic mystical experience. So. There, great. So that's what I have today. Thank you very much for coming.
Question.
You have one question.
Okay, there's space for one question. Sorry.
Yeah, do you see reasons to presume there would be a definite upper limit for how high the doses could be safely escalated in future studies? And also, anecdotes of massive doses of LSD mention effects lasting several days or even a week. Do your results show a meaningful correlation between dosage and effect length?
But was a question sort of, was there a relationship with the higher dose and adverse effect?
No, the first one, or are you asking about my first question?
Yeah.
So do you see that there would be a definite upper limit for future studies, like how high the dose could be escalated for people who are extremely tolerant?
Right, and no, these data don't get at that yet. In fact, so far as the heart rate, blood pressure, and headache adverse effects, we didn't see any relationship really between dose and those. The thing, though, that we really need to look at that, again, we're still working on is that effect on cardiac conductivity in the QT interval. And that I think is what people are going to be looking at pretty closely so far as figuring on whether there might need to be a dose limit.
Mm-hmm. And then do you see a relationship between dose and effect length? Do the effects get a lot longer if you keep increasing the dose?
Is it more efficacious for longer at higher doses?
Yeah.
Oh boy, I haven't seen data to that effect, and it seems to be pretty individual so far as the dose that gets someone to a mystical effect that's therapeutic. I mean, it's been seen at doses down at 20 and even lower, and so.
Yeah, but I mean, like effect length.
Yeah, but you know, we can't go. David, do you want to have a tiny question, if that's possible now?
Yeah, great work and interesting data. I just, did you show any relationship between PK, psilocin level and subjective effects?
And what effects, I'm sorry?
Any subjective effects of the doses?
You know, we administered a couple of questionnaires, so mystical effects and some other things, and those data are still being worked on.
Okay, thanks.
Yeah. Okay, thank you. So, thank you, Randall, again.